Okay, so I'm going to make a start. We've got quite a few more people that are due to attend, but we've got a lot to get through. So I'll make a start and then they can join when they're ready. So good afternoon, everybody. My name is Linda Jones and I'm lucky enough to head up the SBRI Centre of Excellence. So firstly, I just want to thank you all for taking the time to come and attend today's event. And can I just extend a special thank you to all of our presenters that you're going to hear from today. So you're going to hear some great presentations from our colleagues in innovation, but also from our challenge leads. And their presentations are really there to help bring their problem to life, to give you a better understanding of the problem and the challenges that they're facing. And then this in turn will help you complete your application forms, which we're really looking forward to reading over in the next couple of weeks. So without further ado, I'm going to pass you over to my colleague Kieran, who's going to facilitate the session today. So I hope you enjoy it and thank you again for attending.
Oh, thanks, Linda. Afternoon, everyone. Before I start, I'll just run through some housekeeping. So today's event is being recorded and we will share this on our portal. So you're going to hear from lots of different presenters today. And if you've got any questions throughout today's event, you'll see on the top bar that there's a Q&A function. So if we can kindly ask you to put your questions in there and not in the chat box, but in the Q&A bit, that will be much appreciated. So I'm Kieran Jagpal. I'm one of the SBRI Centre's project managers, and we are all very excited to talk to you about our latest challenges. Before we hear from our presenters, I'm just going to give you a little bit of background of who we are and what it is that we do. So you can see there on the screen that that's our website, and we'll post a link for that in the chat. You can find out a little bit more about what we do there. So a bit of background for those of you who don't know, we are funded by Welsh Government and we're hosted by Betsy Cadwaladr University Health Board. And what we do is we work with public sector bodies. So in this case, it's NHS Wales, and we identify their unmet needs. And today we have 3 of those challenges and we're inviting you to solve them with your ideas. So this is the team. We've recently had 3 new members, which is very exciting for us. And if you're lucky enough to go through, this is who you'll be working with. So our role, if you're successful, is to help you in the process. So that might be finding the right clinicians or the end users that can help develop your solutions and make them fit for purpose. And what we do is we facilitate that collaboration and try and make it as easy as possible and streamline the process. And this will be a collaboration between yourselves, the SBRI Centre, NHS Wales and Welsh Government. So I just wanted to show you a few examples of some of the exciting projects that we've worked on before. There isn't time to run through all of these today, but if you want some more details, you can find them on our website. So this is the agenda for today. I'll just run through it. So you'll see on there that we've got 3 presenters. The first 3 presenters are from Welsh Government Innovation, Innovate UK and Cardiff Capital Region. So we've invited them to speak because this is really to help anybody who is new to the SBRI or innovation funding process, and it's just to give you a little bit of background of how and why it works, and they'll have 10 minutes each. And so, as you know, we're launching 3 different challenges today. So our first challenge is safe and ethical disposal of nitrous oxide and Entonox medical gases. I've got to read this off the paper because they're quite long. The second one is how do we improve access to communication for relatives or patients in the hospital? And then the third one is how can we improve ergonomics for ear, nose and throat surgeons whilst performing endoscopic ear surgery. And those presenters will introduce themselves and they've got 20 minutes each. And then we always get a lot of questions about the application process. And to apply for these challenges, you will be applying on the Simply Do application portal. So we've invited Josh down and he will run through the application process for you. And then at the end, Faye from the team, she'll do a Q&A session. So again, if you've got any questions throughout today, if you post them in the Q&A section, and we will do our best to collate them all and answer them at the end. So Kate, our first speaker from Welsh Government Innovation, when you're ready, if you'd like to show your presentation. Thank you.
Brilliant. Hopefully that's come up on the screen. Can everybody see that?
Yeah, I can see it.
Fab. Hopefully that's coming up. So good afternoon all. My name is Kate Williams. I work within the Welsh Government Innovation team. My colleague Tom Doyle from Innovate UK will be going through the wider details of the SBRI process. So I'm just hopefully going to give you a bit of a flavour around what Welsh Government Innovation do, and also why SBRI and the challenge-led approach is so important to us as a delivery mechanism for driving benefits for Wales. So hopefully that'll go across. Fab. So our role within Welsh Government is to support cross-sector engagement and collaboration across the innovation ecosystem. So this means creating the conditions needed to meet our wider innovation vision, which is to foster a vibrant innovation culture in a stronger, fairer and greener Wales. So we work closely with internal and external funding bodies to maximise innovation activity. And we do this by providing information, guidance and support. We also run a programme of events throughout the year and deliver targeted business support through our Collaborative Research Innovation Support Programme, which is CRISP for short. And not only do we promote Welsh Government funded opportunities, but we also work with colleagues from Innovate UK and the Knowledge Transfer Network, with a core aim of supporting Welsh businesses to access the wider UK funding opportunities to maximise the benefits of R&D within Wales. So Welsh Government have been championing the SBRI process for nearly a decade. So we've been helping to support the delivery of small business research initiative competitions since around 2014. So we recognise that SBRI process is a key lever for improving the use of public procurement spend to support innovation, and in turn to use innovation to improve public services. So to date, we've supported nearly 30 challenges being delivered across Wales, opening up public sector R&D contracts in excess of 9 million. And this includes over 3 million in contracts awarded to Welsh businesses. So we've seen a really great level of participation from Welsh businesses and suppliers, but also what we're looking for is not only the best solution for Wales, but where that solution can come from wherever. So it's Welsh delivery, but also making sure that we're bringing those skills and expertise from outside of Wales to hopefully grow the economy in Wales and deliver those benefits more widely. So whilst SBRI is a UK-wide programme, in Wales we are uniquely positioned, and that's due to the Wellbeing of Future Generations Act. So this means that we have a public duty to consider the longer-term impacts of the work we support. So we're looking for not just the economic benefits, but we're also looking for challenges and solutions that can deliver the wider social and environmental impacts. So in terms of these challenges, supporting greater access to sustainable health services contributes to a number of the wellbeing goals, so including a resilient Wales, a healthier Wales, and especially a more equal Wales as well, which is why we continue to work so closely with the SBRI Centre of Excellence team to fund research and development that will address some of the key public health challenges. So for us, what makes a good challenge? The key focus throughout has been upon supporting challenges that can demonstrate scope for a number of important factors. So challenges should lead to development of real innovation. So we're not looking for off-the-shelf solutions. If there was something already readily available, there are other procurement routes that health could be taken to secure those solutions. So what we're looking for are new ideas that can demonstrate that there's a genuine need for R&D to meet those core problems and barriers. We support projects that have a broader market potential so that solutions could be adopted on a wider scale. Many of the challenges that you'll hear about today involve engagement across multiple health boards, with the aim of supporting solutions that can be scaled and can be adapted to meet those wider needs. And most importantly of all, we look to support projects that make life better for Welsh citizens economically, socially and environmentally for today and for future generations. So in terms of the applications that we're looking to see and what we're looking to see from these solutions, there are a few different factors that which for us make a good solution stand out. So SBRI challenges provide a unique opportunity, a unique opportunity to build with and for the end users. It's very much a collaborative process, and one thing that we always say to challenge owners is that the more you put into this, the more closely you work with suppliers, the better the solutions are that come out of the end of it. And again, it's the same for suppliers. This is providing a fantastic opportunity to work closely with health colleagues and frontline staff to develop real solutions that can genuinely meet their needs. So when you're applying for these challenges within that application form, we're really looking for you to show and demonstrate that you understand the challenge and the user needs, and that can actually describe how you'll work with those stakeholders and those end users throughout the process. And we're also looking for solutions that can be brought to market that can be actually adopted by the health services to actually solve some of these challenges. So we're really looking for solutions that can demonstrate a clear scope for commercialization. And a key part of that is being able to demonstrate value for money, and being able to kind of describe what those benefits will be for the health service, and how you'll be able to support that longer term sustainability and accessibility of services for people across Wales. So that's it from me. I'm now going to stop sharing my screen and hopefully hand over to Tom Doyle from Innovate UK. Thank you all for listening.
Hi all, thanks Kate. Just give me a second to try and share my presentation. I think that's presenting, but somebody give me a shout if it's not.
Yeah, we can see that fine, thank you.
Great. So just going to give a quick background to the SBRI mechanism. Really here, this shouldn't take too long. I would rather we focused on the challenges that have been presented. So just to start off, Innovate UK are the custodians of SBRI in the UK. So we advocate and provide support for public sector organisations across the UK to use it where it's appropriate, as well as provide information to BEIS and Cabinet Office, for example, on its use as part of the R&D landscape in the UK. Innovate UK don't own the mechanism as such, no one does, but we do provide a focal hub for use of the mechanism, which is why I'm here from Innovate UK today. So SBRI is a pre-commercial procurement funding mechanism for R&D. It's an alternative to a grant-based approach. And it is tried and tested. It's been widely used across the UK public sector to procure innovation. The biggest users are probably the health sector, as well as defence. So Ministry of Defence through their Defence and Security Accelerator are significant users. So the mechanism provides a structured and supportive approach to share risk and benefits to help development of a product which doesn't exist yet, from a prototype, hopefully all the way through to an end product. So the idea is that this helps innovators work with public sector organisations to develop a product for which there's a known need. That's the challenge. Having that insight from the public sector organisation, working closely with them, is something we found to be very beneficial in the past. And organisations, we've had a lot of positive feedback on that aspect of it. So it helps successful organisations grow their income as well. And additionally, funding from a public sector organisation does bring with it credibility and can help attract further investment. There's also obviously of great help to the public sector organisation. It helps them connect with innovative businesses, and often those that they wouldn't have come across through other procurement routes, and many organisations aren't working at that stage of the technology readiness level on a regular basis either. So it helps them to work with that broad range of suppliers and gives them direct involvement in the development of a solution to the challenge which they have. The idea being that if a solution were to exist, they could utilize it to improve services, reduce costs, or ideally both. So it is a 100% funded, contract for R&D services. I think I might have gone the wrong way there in my slides. Apologies. So although it's worth noting that profit must not be included in those costings as part of the risk-benefit sharing nature of the mechanism. SBRI is the UK's implementation of pre-commercial procurement. It was developed by the European Commission in the mid-noughties, I think, so early 2000s. Interestingly, many European countries give their public sector bodies mandatory targets for spending through pre-commercial procurement. We don't do that in the UK at the moment. It's also widely used in the United States. So I think, I don't want to go into too much detail on the contract side of things, because that will all be in the details, but the contract will be between the funder and the lead applicant only, although subcontracting is permissible. Again, as part of the risk-benefit sharing, there are some usage rights for the public sector, but organisations are encouraged to develop wider exploitation and commercialisation of any products or services that are developed through the SBRI process. So despite the unacronymed name Small Business Research Initiative, it's not just for small businesses. It is open to all organisations. That includes academic and third sector organisations, although any applicants must demonstrate a route to market for the product in the process. So just to give a very quick overview of SBRI at a more strategic level, I suppose. So on the left-hand side there, we're identifying challenges which exist, for which there are no commercially available solutions. And if the SBRI approach is appropriate, at that point, a challenge is identified. And then a series of SBRIs would or could be run in phases, generally awarding a smaller number of higher value contracts as the phases progress, ideally ending in a saleable product or service. That is just the overall ethos. If you like, it's very flexible. Some challenges could start at phase 3, for example, or just do a phase 1 and not have the evidence to justify further investment in additional phases. So just to be absolutely clear, this diagram does not mean there will definitely be a phase 2 or 3 to these challenges today. But hopefully it gives you a flavour of what the mechanism is trying to do. And I think that's my last slide. So I will stop sharing there. Thanks for your time.
Thank you, Tom. Liz, when you're ready, if you'd like to share your screen, please.
Can I just check you can see that?
Yeah, all good, Liz.
Yeah, okay. Hi everybody, my name's Liz Rees. I'm the Challenge Fund Project Officer working for the Cardiff Capital Region. I'm just going to talk a bit about what we do and how we work with the SBRI Centre of Excellence. So firstly, just a bit about what the Cardiff Capital Region is. It's part of the City Deal programmes, which is a collaboration between 10 local authorities in South East Wales, highlighted on the map, the UK government and the Welsh government. And the whole point of the programme is to sort of build on the sectoral strengths of the region, utilise the skill base and the universities that are within the region to accelerate economic growth and productivity for the region. So it will deliver targeted investments in areas such as skills, infrastructure, innovation and priority industry sectors and businesses. It's a 20-year programme, so it is a long time, and the outcomes are hopefully 25,000 jobs, an additional 4 billion of private sector investment and an increase in GVA of 5%. The priority sectors for the region, you can see them there. So they're compound semiconductors, financial technology, cyber, creative economies, medical technology, transport, energy and environment. We also have 4 key areas of focus. So they are skills, digital, sites and property, and innovation, which is what the Challenge Fund comes under. So the Challenge Fund is a £10 million fund delivered by our partners in Cardiff University. And the fund allows public sector bodies, such as health boards, to engage with the market, with businesses, to develop innovative solutions to challenges they're facing. So these solutions must be new, they can't be off the shelf. They must be able to be commercialised and scaled up. And these solutions must drive economic impact for the region, so build local wealth, or whether it's by jobs or supply chain, etc. So the current priority themes for the programme, these are likely to change, but at the moment they're accelerating decarbonisation, so things such as improving air quality, public transport, decarbonising fleets, homes, etc. Improving health and well-being of citizens, so this could be projects to do with social care, loneliness, etc. And then supporting and enhancing communities, so this is things such as town centre regen, rural community projects, food security, etc. I'm just going to run through the funded challenges to date. So the tracheostomy challenge, this was Cardiff and Vale Health Board, and the SBRI process was delivered by the SBRI Centre of Excellence. And the aim of this was to develop alternative training methods for the tracheostomy procedure during the COVID pandemic, when in-person training wasn't possible. So the funding came from the Challenge Fund and Welsh Government. That was £400,000. The challenge is now complete very successfully, and the procurement of that is ongoing and hopefully will be spread across health boards in Wales. And we've got 4 electric vehicle challenges. So these are Caerphilly, Merthyr, Monmouthshire have 2. These are local authorities, and this is about transitioning their fleet vehicles to EV to meet their net zero targets. So we approved just over 1.5 million in funding for that. And Merthyr is currently live and on site. Monmouthshire will be starting shortly, and Caerphilly has been slightly delayed. Then the other health board one, again for Cardiff and Vale, this is an endoscopy challenge, and it's to address the long waiting list for endoscopy procedures in Wales, which has been exacerbated by the pandemic. We've approved £750,000 for that, and they're currently going through a procurement process to find solution providers to develop innovative solutions. So yeah, that's a whistle-stop tour of the Cardiff Capital Region and the Challenge Fund and how we work with the SBRI Centre. For more information, you can drop us an email, ccrchallengefund@cardiff.ac.uk. You can go to our website, challengefund.wales, or you can look us up on Twitter, which is @ccrchallenge. Thank you very much. I'll just stop sharing my screen now.
Thank you, Liz. So Charlotte, when you're ready, thank you.
Hi everyone, I'm hoping that you can see my presentation up on your screens now. My name is Charlotte Oliver. I'm a consultant anaesthetist in Cardiff and Vale University Health Board, and I'm going to be giving you a bit of the background and a bit more information about the first of the challenges today, the safe and ethical disposal of nitrous oxide and NOx medical gases. And I'm presenting on behalf of a challenge team based in Cardiff, but we do have links across Wales for this project. So a bit of background information to begin with for you all about nitrous oxide itself. Its medical properties that we exploit are its pain relief abilities and also its use in sedation. Nitrous oxide can be supplied as a pure gas, and in that situation it's used by anaesthetists who we blend it with oxygen, and we can receive nitrous oxide either in a piped supply from a manifold, as you can see in the image on the bottom image, or it can be utilised directly from a portable cylinder, as you can see in the top left image. When it's delivered as an inhaled gas, so it's either breathed in directly by patients or added to the breathing circuit during an anaesthetic. So it's inhaled by the patient, it doesn't get metabolized at all by the body, and so then is exhaled by the patient, and then as a result of that exhalation, it is then released directly into the atmosphere. We can also use nitrous oxide as NOx, And Entonox, also known as gas and air, is a 50-50 mix of nitrous oxide with oxygen. So this is a safe gas which can be directly inhaled from the cylinder again, or from a piped supply from a manifold room, as shown in the image below. That's our manifold in Cardiff and Vale. And this is predominantly used in labour analgesia. It can also be used in procedural sedation, such as in dentistry and endoscopy, and is also used by our emergency department and pre-hospital by the Welsh Ambulance Service to provide analgesia whilst patients are being transferred, and also for short stimulating procedures. It's a safe gas, it's very cheap, and it's effective at what it does in providing short-term reversible pain relief. So what is the problem with nitrous oxide? It's a greenhouse gas. It has a global warming potential 300 times greater than carbon dioxide. In addition to this, it persists in the atmosphere for 114 years and is ozone depleting. So it all contributes significantly to global warming. Alongside the environmental concerns, there are also health concerns about long-term exposure to nitrous oxide, and you may have seen articles in the news about this recently. It's been linked to some of the health problems such as B12 deficiency, neurological damage and fertility issues. And the graph on the right just demonstrates how our atmospheric nitrous oxide levels have been increasing since the time of the Industrial Revolution, and currently on an exponential curve upwards. So how does healthcare contribute to that nitrous oxide and our CO2 emissions? This pie chart is been produced by the King's Fund, NHS England made it, and it's a breakdown of how different parts of the NHS and healthcare contribute to our carbon footprint. Overall, healthcare in the UK contributes to 5.6% of the UK's CO2 emissions. And if you looked at healthcare on a global scale and added up all the carbon footprint from that, we'd actually be the 5th biggest nation if we were acting in that way as a global emitter. So going back to the pie chart, you can see I've circled the anaesthetic gases and metered dose inhalers, which make up 5% of the total NHS healthcare carbon footprint. But actually, if you break that down into just the NHS carbon footprint for direct emissions, it's about 20% of the direct emissions from the NHS. As well as nitrous oxide, we do have other anaesthetic gases that make up that 5%. And there is ongoing project work which has been started to try and start to address this problem. So we have got the NHS Wales decarbonisation plan, which is our framework for decarbonising the NHS. And within that, we have got specific mention of the anaesthetic gases. We've got structures in place such as Green Health Wales and the Global Green and Healthy Hospitals Initiative, which are supporting healthcare in its decarbonisation. You can see from the pie chart, this is our local data from Cardiff and Vale. We have started local projects, and there are local projects in health boards across Wales and also England, looking at how we can reduce our emissions from anaesthetic gases. So the pie chart shows each of the individual anaesthetic gases and how they contribute in terms of CO2 equivalents in tonnes of CO2. By far the biggest section is from Entonox, delivered from a manifold, which makes up about 3/4 of our carbon footprint from medical gases. And then another almost quarter is from our manifold nitrous oxide. So if you want to reduce the carbon footprint of the NHS, we have to address medical gases, and by far the biggest contributor to that is nitrous oxide, either as pure nitrous oxide or Entonox. So we have a lot of potential to improve our carbon footprint by tackling the nitrous oxide problem. A bit more detail on some things that we have already done in Cardiff. So I've mentioned before, we've got 2 ways of supplying nitrous oxide, either from a manifold, which is then delivered through pipe work in the hospital, or directly from nitrous oxide cylinders, we have compared the efficiency of those two systems and found that the direct supply from a cylinder is a lot more efficient than a manifold supply. And so we've actually converted the whole of Cardiff and Vale now onto a cylinder supply and are in the process of decommissioning our manifold supply. And we predict from that we are going to reduce the waste in that system significantly. But having carried out that project, we are left with a problem. And this is the first of the problems that's covered by this challenge. We've got multiple remaining G-size cylinders containing 9,000 litres of nitrous oxide on site. We receive these from BOC, the British Oxygen Company, and if we return them to BOC, then because nitrous oxide is classed as a medical drug, it will be vented to atmosphere. It cannot be reused or recycled under current legislation. So we want to prevent this being returned to BOC and vented to atmosphere, because that will contribute to the environmental issues. So how can we safely dispose of these nitrous oxide cylinders? That is our first problem that we would like to address without them being vented to atmosphere. Looking back at the previous pie chart, Entonox was our biggest contributor to our carbon footprint. Entonox is used in a different way to anaesthetic nitrous oxide. A portable cylinder system is not suitable for areas where the usage levels are high, such as in maternity units. So we are working hard. This is our current strategy for managing Entonox in Cardiff and Vale. We're working to move to cylinders in low use areas, such as the emergency department and endoscopy, working hard with estates to maintain our current pipework supply, fixing leaks and improving the manifold location. And we have also started using innovative technology, which is able to crack exhaled nitrous oxide. What that does is it heats it, and that splits the molecule back to nitrogen and oxygen, which are our normal components of air. The current options for capture and cracking are very limited and expensive. There's only one company which has a product on the market, so they have a monopoly, and it's as I said, it's an expensive option. We currently don't have any systems in place that allow a circle system or a rebreathing device for Entonox. If we were able to use those kinds of devices, we would reduce the need for a manifold supply, and we would be able to move from a system where all of the Entonox that is breathed in is exhaled to move to a more circular system where the patients are able to reuse the Entonox, the nitrous oxide that they have already used. So what can be achieved if we are successful in this challenge? So in Cardiff and Vale alone, we currently emit 4,500 tons CO2 equivalent from Entonox each year, and just one G-size cylinder of nitrous oxide is equivalent to 5,000 kilos of CO2 equivalents. As I've said before, we cannot achieve the public sector net zero goal without addressing medical and anaesthetic gases, and as we have seen, nitrous oxide is the vast majority of this, makes up the vast majority of anaesthetic gases. So we can't ignore nitrous oxide. We have to deal with this problem if we want to achieve net zero. So in summary, the project goals for this project is to reduce the healthcare emissions from nitrous oxide, and the ideal solution would enable safe disposal of nitrous oxide and Entonox cylinders, and it would also enable Entonox use with low nitrous oxide emissions to the atmosphere. Thank you very much. I will be around hopefully for the start of the Q&A, so please let me know if there are any questions.
Thank you, Charlotte. Thank you so much. Tracy, over to you when you're ready.
Thank you. That should just be on its way on the screen. Okay, is that there?
Yeah, brilliant. Thank you.
Lovely. So hello, everybody. My name's Tracy. I'm a consultant nurse for dementia here at Betsy Cadwallader, and I'm co-presenting today with my colleague Louise Thomas from telephony. So as you're aware, our challenges around communication with families and also reducing staff time dealing with how we get information to families. So hopefully what we're going to cover now is going to paint an accurate picture of the reality of what this challenge is presenting to us, the context it occurs in. And I'm just a vehicle today for my many colleagues and family contacts and patients to relay the concerns and experiences they have with this issue. So to start off with, anyone working in health and social care, generally speaking, has the same goal, and that is to help patients and families have person-centred care. So making sure their individual needs and preferences are identified, considered and met in a way that they wish. So attachment and inclusion are really important psychological needs of those different people and staff as well, to be fair. So people thrive with close and trusting relationships. People want to be comforted in situations that might be alien or difficult for them. And people want a sense of belonging, whether that's to a group, family, friends, some kind of community, and so on. And family engagement is something that's a golden thread throughout everything that we do. So active involvement and engagement, involvement in decision making that affects them or their loved one, and so on. But again, identifying their needs too. So our inpatients have numerous routes to get into our services. Sometimes that can be with very short notice, coming through emergency routes. Others might come for elective planned surgery or be sent in by a GP, for example. And length of stay can be variable. It can be extremely short, a few hours, 24 hours, many months, and in very rare occurrences, maybe perhaps over a year for some kinds of patients. But what's common amongst those patients is they all have, and their families have, a need for information that's timely, appropriate, gives them what they need about the patient's condition. And sometimes families and friends want information about basic things like visiting hours or where the parking is or what time's the canteen open, etc. And sometimes it's more interactive about wanting to look at discharge planning and what's needed, what do we need to get in place and when might that be, etc. But a large bulk of the information needs is updates. How did such a body sleep? Have they had a good day? Is the pain under control? And it's often not just one family member that needs that information. And there can be quite a burden on one family member relaying it to other family members and friends. And some families and networks can be quite extensive. So there's a pressure on to try and share that information through a single point, often, if you like, or repeated calls will be made by different family members, often asking for the same information. Traditional telephone is the current means of people accessing that information. So more from my colleague Louise in a minute about how that works. But it's really well evidenced that families benefit from being engaged and informed. Being connected enhances patient well-being as well. Again, there's lots of research to say that patients who can relax knowing that their family's okay, as well as families who can relax knowing that the patient is okay, helps them both with their well-being. It helps recovery, helps reduce the psychological distress, and shortens length of stay in hospitals, which is really important at the moment. And it's important that recovery isn't always what the goal is. Sometimes people are in hospital for end of life care. So again, different kinds of information needs, but people need prompt, detailed, appropriate information accessible to them at all times of day and night. So family stress levels can be high, partly due to the current weaknesses of the telephone systems that we have, but also staff are pressured by sheer number of call volume, and we'll share some numbers in a minute. Interruptions to clinical care. There can be pausing, maybe helping somebody to wash, walking up the wall to the phone stops ringing when you get there, you go back again, it rings again, or maybe having to remove protective clothing, interrupting somebody's wash, taking off some clothes, some protective clothing, washing hands, and by the time that's happened the phone can stop ringing, and so on. And then just share the sheer mileage of it all, if you like. So there's been a variety of non-technical solutions tried. Some of them with reasonably good effect, I have to say. So some wards have tried things like just ringing for the families of patients in beds 1, 2, 3 and 4 on a Monday, 5, 6 and 7 and 8 on a Tuesday and so on, which has worked reasonably well if people only want a weekly phone call, or if patients move beds, then that can go a little bit amiss. others have tried other solutions, such as having a dedicated staff member to ring all the families in the afternoon. Well, that's great if you're not working in the afternoon or busy doing something else, and you can take that call at that time. But again, it tends to focus on one particular person. So some attempts at solution, but we need help with this really, and we're obviously hoping that you can help us with that. And just to finish my section, here's just a couple of illustrations of the mountain of feedback we get from families and others about this issue. So families who've experienced patients being transferred from Wrexham Mile Hospital to SBRI Glenclwyd Hospital, quite a distance, and then struggling to get communication to know what's going on, what's planned, when the move was planned to happen, when it did happen, and how the person's transferred. And then a second one there about families worrying about not getting communication or update from a ward. Really key for them because the patient was quite confused, so that's added stress for the family, and perhaps an impending transfer to another geographical location, so again a big deal for the family. And then the third one around poor communication between staff and patient is sadly, sad to say, is a common one, that people just don't know what's going on. They can't get through to the ward at all on many occasions. So I'm just going to progress the slides for my colleague, Louise. Over to you.
Thanks, Tracy. Hi, my name's Louise Thomas. I'm the Telephony Services Manager for Betsy Cadwallader University Health Board. I've been asked to be part of this project because I've got a vested interest in the switchboard staff who I manage. So I manage not just the telephony services, making sure that Betsy Cadwallader users of the service get the best service, but also that the switchboards are also managed and that they have all the information that they need. So one of the challenges for us is that the wards are very busy, and at the 3 district general hospitals, at Ysbyty Gwynedd, Glenclwyd Hospital and Wrexham Mile Hospital, the ward phones are not answered. They're either not answered or they're busy. So it's an ongoing issue with relatives phoning into the wards to get news of their loved ones and calls not being answered or the phones being engaged, resulting in them not being able to get through to the wards. This has a knock-on effect on the switchboards and the staff that man the switchboard. Calls often come back to the switchboard, and then it prevents the switchboard from transferring other calls. So that results in low staff morale in the switchboard, frustration and distress when having to deal with any upset or irate relatives. Tracy, if you could just change the slide for me, please. So, I think it's a common thing now that people know that the organisation realised that the patient relatives are receiving a very poor service, and the experience that they're getting when contacting the wards, it's just not adequate. Many of the calls becoming upset, as I said, and irate with the switchboard staff because they're the only people they can actually get through to speak to. And switchboard staff are not equipped with providing any information about patients because they are really a hub for just transferring calls between A and B. So we'll just move on to the next slide. So as I said, we've got a switchboard presence at the Ysbyty Gwynedd, Glenclwyd and Wrexham. We take around 4 million calls per annum. So those calls come from the public, relatives, patients wishing to be transferred to wards or departments. Most of the calls are for wards. Each ward have about 3 or 4 extension numbers. So the process that they follow is the switchboard operator transfers the call to a ward, which is often engaged or there's no answer. The operator then tries one of the other available extension numbers to transfer the call to. If the call's not answered, the call comes back to the switchboard as an automatic transfer, leaving the operator with an option to try the numbers again or ask the call back. Now, all of this takes time, and already this callers are starting to get quite impatient and they're not getting the information they need. Another sort of example is that once one call has failed to be transferred and is on hold, so that person might have been, they might have tried to transfer that call 3 or 4 times. Then they've given the option for the caller to be placed on hold.
system, there's current limitations on the system where switchboard, if they then take another call for the ward, they're unable to transfer it because they've already got a call on hold. So that's creating a problem for our staff on the switchboard. If we could just move on to the next slide. So as I said, all this delay for the relative encounters in getting through to the ward to get news of their loved ones can create distress, upset and dissatisfaction, which the switchboard staff bear the brunt of, as I said, resulting in low staff morale, frustration and distress when dealing with an upset or irate relative, because they're trying to provide the best service they can for those relatives, but you know they come to a point that they can't do anymore, and they're left with feeling dissatisfied because they can't help that person. Patient relatives are, as I said, receiving a poor service, and it's been reported that this is the biggest dissatisfaction raised by relatives to our patient experience team. So it is a big issue. It's worth noting as well that relatives are able to call in to the hospitals on a direct dialing number if the wards have provided that number to the relatives. But again, that comes with problems because they'll phone that main direct dialing number, but they'll experience the same issues with calls not being answered or being permanently engaged. So that leaves the caller with no options, but to either try again later, hang up and try the main hospital switchboard again, and then they're back to the same situation where they could be trying all day. I've known people been trying for days to get through, which is not adequate. So if we could just move on to the next slide. So I don't know whether Tracy wanted to talk about this, but this was just a sample figures from one of our hospitals for two separate departments. So we've got the AMU and the SAU departments, their extension numbers, the calls that they take in, and how many of them are unanswered. So you can see from that the main issue is that the calls aren't being answered, and that could be a number of reasons, that they don't have adequate ward clerk staff to answer the phone, they don't have other staff to answer the phone, they're busy on the wards dealing with patients. So yeah, it looks pretty poor, and it's something that everybody is feeling. Okay, that's it for me then. Thank you, Tracy.
Yeah, thank you from me too.
Oh, thank you, Tracy. Thank you, Louise. I'm just going to share my screen again. Hope you can all see that. So we've heard from two of our challenge leads today. So the one for the gases, as we've shortened it to, and the one for patient comms. So we're just waiting for Dr. Sam Fishpool to join the call because we're running a little bit ahead of time. So Josh, what I might do is I'll run through some key dates, and then perhaps I could hand over to you and we can just switch the agenda around a little bit.
Yeah, of course. Just let me know when you want me to jump in.
Okay, thank you. Okay, so you can see some key dates there. So for anybody who's applying, so the deadline is 2 weeks today on the 14th of December. It's a hard deadline of 12 o'clock noon. And, you know, we always advise that you apply early, because it can always, you know, there's on the application process, it might just take you a little bit of time. So if you're successful, week of the 19th of December, we will notify you and let you know. And then we are aiming to start project work in early January, with phase 1 completing in the 31st of March, at the end of March. Just to let you know that this today's recording will be available on the Simply Do portal as well. Okay, Josh, over to you if you're ready.
Super, thank you. I'll just share my screen now.
Oh, actually, Josh, Dr. Fishpool is here. So Sam, I don't know if
yeah, of course.
I don't know if you'd like to go through your presentation.
Yeah, if now's good, yeah, absolutely.
Yeah, when you're ready, if you'd like to share your screen.
Yep. There we go. Can everyone see that?
Yeah, brilliant. Thank you.
Brilliant. Okay. Okay, well, yeah, I'll commence the presentation if that's okay.
Yep, go ahead. Thank you.
Yeah, fine. So, yeah, I'm Sam Fishpool. I'm an ENT consultant in Cwmtarf Morgannwg UHB. And the challenge we've proposed really is about improving the ergonomics of endoscopic ear surgery. So I'm an ear, nose and throat consultant, and my particular specialty is ear surgery or otological surgery. When we think about ear surgery, we can operate on the external, middle and inner ear. We're going to be talking about, in this challenge, endoscopic ear surgery, which is primarily a technique that's evolved in the past decade or two for use in middle and inner ear surgery in particular. There's a variety of indications for this kind of surgery: the removal of tumours, benign or malignant, the eradication of acute or chronic infection, hearing restoration surgery, and sometimes balance restoration surgery too. So traditionally, this surgery has been performed with an operating microscope. And you can see here one of our trainees, Dan, one of my consultant colleagues, Mr. Smith, doing a simulated otological operation using the operating microscope. This technology has been available since about the 1950s and still performs a lot of the workload of otological surgery and other surgery in the head and neck area. However, in the past decade or two, advances in endoscope technology have opened up a new operative technique called endoscopic ear surgery. This has a number of advantages, and it does have some disadvantages too. I'll speak through the main advantages. And the primary advantage is the excellent field of view that you get from using the endoscope. There's a small schematic on the right side of this slide that I'll just talk you through. So the pale blue lines show the convexities of the ear canal on either side, and at the bottom is the flat tympanic membrane. The left image shows the ear canal with its convexities and this narrow isthmus in the mid-third of the ear canal. If you shine a light from outside the ear, i.e. with the operating microscope, you get a column of light that's restricted by this isthmus, and thus you can only see a small portion of the tympanic membrane. Almost invariably, this requires external incisions around the ear to open up the area to allow for the operation to occur. The right image shows the endoscope. So the endoscope is able to pass through the narrow isthmus, and the wide field of view afforded allows you to visualize the entire tympanic membrane. Also, when one enters the middle ear, again, this instrument allows you to see the recesses of the middle ear where one can clear tumor or chronic infection from. This endoscopic approach gives a number of advantages. Because it's almost invariably purely transcanal, you don't have the related incisions around the ear. This leads to reduced operative time, as you don't have to open the ear and close the ear thereafter. And for the patient, reduced post-operative analgesia requirements, because there's no incisions, and reduced inpatient stay. However, ENT surgeons do have issues with musculoskeletal problems in particular. A recent national survey showed that 72% of British ENT consultants suffered from back or neck pain, with over half of these attributed to their surgical work. We'll see some images. We've seen some recently of the microscope, but I'll show you some images with the endoscope as well. showing you the problems that occur, particularly for otologists, ear surgeons. Quite often these operations can take 2 to 3 hours, and the upper limbs in particular are forced into some curious positions that one has to hold for a number of minutes into hours, with the fine micro movements associated at the distal end of the limb as well. So more than half of ENT consultants who've suffered from these musculoskeletal problems require medical treatment, and quite a proportion, 16%, have time away from work, which is high compared to other specialties. And almost every ENT consultant will know of a colleague somewhere locally who is off for weeks into months with musculoskeletal problems related to the use of predominantly the operating microscope and the endoscope. So here's an image of one of our medical students, Amy, who is right-handed, in a simulated endoscopic ear case. I'm the simulated anaesthetist in this picture. You can see Amy is right-handed and using the fine forceps with her right hand. The endoscope she holds with her left hand and introduces it into the ear canal. What you can note here is the unsupported left elbow. And over the course of an operation, classically 60 to 90 minutes, but can be up to 3 hours, that endoscope's going to have to be supported, moved around the ear canal, taken in and out to clean the lens. And it can be quite sore at the end of the operation, especially around the left sort of shoulder girdle area. Interestingly, for the right-handed surgeon, as Amy is in this picture, operating on the left ear is easier. One can rest the elbow on the operating table, or one can put a pad over the patient and rest it on the patient's shoulder itself. And this converse is true for the left-handed surgeon. So we ran a small project in combination with a research physiotherapist, John Rice, medical photography, and Mia, another medical student. And we set up a simulated operating theatre. And we had myself at 6'1", and one of our junior doctors, Manar, at 5'1", performing simulated surgery. We took some pictures and we had John assess our positioning and posture and try to assess the ergonomics of the operating. John identified some other issues as well. So in both these images, you can see right-handed surgeons operating on a patient's right ear. You can see the unsupported left elbow in both images. But you can also see the height discrepancy. So poor Manar, despite the low operating table, the chair is up high, the feet are floating in the air, as is her left elbow. For me, it's slightly more comfortable. I've got my feet planted on the floor, but I've still got the floating left elbow issue. So the other thing from the literature that's spoken about with endoscopes is hand size as well. And these endoscopes with the attached cameras and light leads can be heavy, and that can cause strain too. So our challenge is, and the solutions we're looking for, are to make this operation more comfortable for the surgeon. We're hoping that this would reduce musculoskeletal problems in future in our workforce, have less sick time, or have quicker operations performed by healthier surgeons for the benefits of our patients. So that does bring to an end my presentation. So if there are any questions, I'd be happy to take them.
Brilliant, thank you, Sam. I think what we're doing is we're going to do a Q&A at the end of the session, and we're nearly at that point. So Josh, if you'd like to do your presentation next.
Super, thanks, Kieran.
Thank you, Sam.
Thank you.
Okay, so I'm just going to spend kind of the next couple of minutes just walking through the SimplyDo platform. As a supplier, when you engage with this process, you'll be required to submit via the SimplyDo portal. So I'm just going to walk you through one of the challenges and the application process so that it's easier for you when you get in there. So where the links for SimplyDo will probably be shared in the chat at some point. But when you do click on a link, you'll arrive at what's called the challenge page. So as you can see, this is the page for the challenge that Sam was just going through. The Simply Do challenge page will contain all the information around the open call, so around the challenge background, what the details are of the challenge, if there's any scope, key dates such as when it opens, when it closes, the briefing event, which is obviously today, and then the phase structure and any further information. So essentially all the information you'll need about any particular challenge that you access on Simply Do will be provided on this page here in terms of how much funding there is and so on and so forth. There's also the SBRI contact email, and the slides for today's session and the recordings will all be placed onto Simply Do and in this area here so that you can access them. And then there's various helpful links and documents, FAQs. So I recommend having a quick look and glance over some of those before completing your application. Once you've read the information and you're ready to proceed, just click Create Your Idea. And at that point, you'll be required to create an account or log into an account. And I'm just going to log into one. And then what you'll see is essentially the form that you need to complete. This is the idea format that you're going to complete as a supplier. There are various sections of that format ranging from details of your organisation right through to your solution and how you're actually going to solve this challenge. The information will update and will save as you go through it. If you would like to work on the submission collaboratively, you can come to the left-hand side and click Add a Collaborator. This will send an email directly to the person you want to collaborate with, and both of you will be able to access, complete, and submit this idea. So as we go through it, the first section is just around the application itself. The second section is just around your organisation, so it's just putting in your organisational details. The third section is the contact details. So those three shouldn't take you long at all. You've all probably got that information. And then as we move into the kind of bulk of the submission, there's a section around your submission. So what it is that you're kind of proposing as your submission here. A section around ease and readiness and kind of project plan. All of the questions have got 1,000 word limits. So you can copy and paste the information from somewhere else. And then work your way through this challenge form, working your way from top to bottom. And then once you've completed it, all you'll need to do is click submit. That will then come through to the SBRI team, and this will then be sent out to the assessors who will be assessing all of the submissions in platform. If you have any problems at all from a technical standpoint and you want to ask any questions around, how do you add a collaborator, or you can't find a certain section, you can open up a conversation with any of myself or another member of the Simply Do team by clicking this button in the bottom right-hand corner and just send us a message and start a conversation with us. And I'd be happy to help you with any kind of technical aspect of Simply Do platform. Otherwise, any questions can be directed through to the SBRI team. Okie dokie, that's myself, Kieran. If anyone's got any questions, I'm happy to field those as well.
Oh, brilliant, thank you. Just for everybody to know, Josh mentioned that in the there's a helpful links and docs section. So in there's an example of the SBRI contract. So just to note that this is a standard non-negotiable contract, and this is used for all SBRI. So if you're successful, this is what you'll sign and agree to. So I can see there's a few questions in the Q&A, so I'll hand over to Faye from the team.
Yeah, we've got a few questions through. I'm just going to go with a couple. There's two from Janet Jensen about the G cylinders, so I'm just going to put those questions to Charlotte if she's still on the call.
Yeah, I'm here.
Right, okay. We've got two questions. G-size cylinders, is this 100% N2O or is it 50-50 N2O02? And also,
it's our yeah, it's 100% N2O.
Okay, thank you. And he's also asking how many G cylinders total is expected and how many hospitals should be included?
So our site, we've probably got about 20 on our slides, but I actually foresee this having wider applications. So I think every hospital will have this issue within Wales, but actually also within the UK. And I think it's also could be looked at on an international level. It's going to be something that a lot of nations are looking at. And I also think outside of healthcare, nitrous oxide is used in other areas as well. And it's something that as other industries decarbonise could have applications there as well.
Thank you, Charlotte. I've just got another couple of questions, potentially for Kate. This one, there's a question from Alex Knight. Is it acceptable to integrate a number of existing off-the-shelf technologies in the development, a new and innovative solution delivered as a new productized solution?
Yes, certainly that would be applicable. Obviously, within the application form, we'd look for you to kind of describe what wasn't suitable about the existing solutions and why that innovation and that adaptation is needed. But yeah, certainly we're not looking, it doesn't have to be a brand new solution. It's about how we can kind of adopt and adapt existing solutions to fit this particular need. So as long as you can demonstrate that there is a need for R&D and innovation and how that will solve the problem, then yes, certainly that would be applicable.
Thank you, Kate. There's just another couple of questions towards the patient comms challenge, so I'll just put those possibly to Tracy or Louise. Alex Knight is asking, can we assume that much of the information needed by families about patient conditions and plans are already being recorded in existing hospital clinical systems?
Sorry, I just missed the beginning of the question. Could you just repeat the beginning?
Yeah, of course. Yeah. Can we assume that much of the information needed by families about patient conditions and plans are already being recorded in existing hospital clinical systems?
I would say not, because the way they're recorded is for a different purpose. It's for staff communication, generally speaking. So it's not written in a way or with content that family necessarily wants. So I would say not.
There's another question on the same challenge from Kate McCauley. So she's asking, what electronic patient record systems are used at the 3 district hospital sites? So I guess Tracy and Louise, you're able to answer in terms of Betsy. Yeah.
Yeah, I don't know the actual names of them because I'm too new to the health board, but there are several, and that's one of our challenges, that we've got numerous numerous data systems for all sorts of things, but we've certainly got several ones of those, and we are just in the process of rolling out a new nursing care record, but it's only in part of our health board at the moment. It's just going through rollout currently.
Too many more questions. There's just one more potentially for Kate or Tom from Innovate UK, just about from Janet Jensen again. Do you need to be a UK supplier to enter the challenge?
Happy to answer that one. So yes, you would have to be either a UK or an EU supplier. So you have to be a legal entity and within the EU or UK in order to be the lead applicant on this challenge.
Questions just come through now from Gagan Baludi. If I'm a clinician working with a software company, can we submit an application jointly? Sorry, Kate, I'm going to come to you again.
No worries, I should just leave my camera and mic on, so switching on and off all the time. So potentially, what we would probably look for is that the software company would potentially be the lead and perhaps the clinician as stakeholder. I think with things like that, we probably have to consider it on an application basis, especially in terms of who's the funding, who's the health board that's funded, but certainly be open to collaboration on that front. The main thing is that for whoever applies is that they're able to demonstrate that they are capable and in the position to be able to commercialize that product and bring it to market. So however that application and that subcontracting relationship or partnering relationship is handled, it needs to kind of clearly demonstrate, if you're successful in developing this solution, who and how will you bring that to market?
Okay. Another question's come through again on patient comms from Andrew Conkey. Will users be made available for interviews by the patient info challenge owners? So I guess that's in terms of the...
Yeah, we very much value co-production, working with patients and families, so we could absolutely coordinate that for sort of co-design sessions.
Tracy, a follow-on question from Andrew, also for the patient info challenge. Will technical integration with NHS Wales IT systems be possible in phase 2? Not sure
I can answer that one.
Hi, from a telephony point of view, yes, I'm sure that we'd be able to integrate with our current telephony system and clinical systems as well. We just need to get into conversations about the technical technicalities of that. I'm not technical myself, but we do work with third-party suppliers, so we're open to looking at integration and anything that can enhance our current systems.
I think there's another similar question there from Dermot that's come on about, is there integration support available to facilitate the patient information challenge? So potentially you just answered that, but just a reminder that it will be, other health boards will be involved in it too. And obviously Tracy and Louise, you can answer from a Betsy's perspective. Linda, did you want to add something?
I did, thank you. Just in terms of integration with DHCW, what I would say with that is DHCW, so that's the National IT department for Wales, where all our national systems go to. They have their own work that they need to do. So in terms of, we can work with you to have discussions with them, but 9 times out of 10, the integrations to the national systems don't happen with an SBRI. If it's within the health board's gift and they have local document repositories and things that we can integrate to, then we can, that's definitely within our gift to do. But in terms of the national, then I'm going to say that probably it's out of scope. Thanks, Faye.
Hey, I'm just going to come back to you. You just answered a question about from the application from the clinician with the help within the health board and the software companies. Just followed on asking, does the health board need to be part of the application?
No. So a number of health boards have, as part of these challenge deliveries, there's a number of different health boards involved. So in terms of that kind of strategic level, that'll be kind of organised by the challenge owners. So no, the health board wouldn't have to be part of that application. The only thing to be considered, and it's not something I can advise on, would be the intellectual property access. Is whether or not, if you're employed by a health board and you're acting on their behalf, there will potentially be questions around who would own that IP. If it's an integral part of your role, there can be crossovers with the health boards potentially having some ownership. I can't advise on that. That's not something that's kind of in my experience, but it's just a caveat to warn you that just you might need to look into that and find out a bit more on that if it's directly linked to the role you're already employed in. So yes, some external advice might be useful for you on that front, but no, the health board doesn't need to be part of the application. Thank you.
Thanks, Kate. I think that was all the questions, but I'm hearing that some people are not able to access that depending on how they've come into the meeting. So I've just had a message flagged from the chat. I think there's a question there from John Griffiths asking about what's the cash flow if successful in the challenge? Is there a payment schedule or paid on completion of the project? So I'm not sure who on the panel can answer that one. I just have a look for any more questions.
I'm happy to answer that one if it's helpful. So.
Great.
SBRI challenges, they're, as I said, they're a contract for R&D, so the payments are made on deliverables. So there will be a payment schedule that will be agreed as part of that contract, which will be linked to a project implementation document, so that those payments are made against the key milestones. What we don't tend to do is see a huge proportion of costs up front, because as I said, we're looking for the deliverables. So it's once the work's completed. But that would, so for a feasibility project lasting for 3 months, that as an example, it can be monthly or it can be tailored to what the supplier needs. But yeah, there'll be a payment schedule agreed as part of the contract. Hopefully that's useful. And Belinda, please correct me if I'm wrong on these projects. I'm just kind of going on the general, this is what we do.
No, that was perfect, Kate. Thank you.
Thank you. And there's just another question coming from Gagan Baludi. Can pilot place for the solution be any health board, or should it be BCUHB? So just Betsy, or can it be any? I think that's on the patient comms one, just following on from further question.
Shall I answer that, Faye? Might be
Thank you.
easier. So Betsy will be the lead health board, so I would say yes. But what we're trying to do, and what we try and do with SBRI, is get other health boards involved from across Wales. So you might be talking to a lead today. So you've been talking to your consultant in ENT in one health board, but actually we're working with a couple of ENT consultants. So no, not just BCU. You could find it could be a couple.
I think that covers all of the questions. I think there was just to point out, I think somebody did join slightly later and missed some of the presentation. It's just a reminder to everybody that all the presentations will be put onto the Simply Do portals on the relevant challenge pages. So if you have missed anything and then you look at the presentations and you have got a question, just feel free to send an email through to us and we'll come back to you, or we'll add it to Q&A that's missed and put on the challenge page. I think that's all the questions. So I don't know, back to you, Kieran.
Oh, thank you, Faye. Okay, well, just if there's nothing from anybody else, unless any of the presenters or speakers wanted to add a comment, or from the SBRI team, if anybody wanted to say anything, I guess that concludes today. So it's just a massive thank you to everybody who's presented on behalf of the SBRI team. You can see on the screen there's a link to the challenge page on the Simply Do portal. And if there was any other questions that you can think of, there's an email address there that you can send those to, and all of the questions and answers from today's event will be on the Simply Do portal as well as the recording. So yeah, thank you. Phil, final comment from Phil?
Yeah, sorry, I was just going to chime in and say thank you to the SBRI team for setting this and hosting this. Thank you for everyone who's attended. I'm Phil Coles, the Chief Clinical Innovation Lead for SBRI, and super excited about these 3 challenges. And I just wanted to comment really that based on the fantastic presentations from our 3 speakers, Charlotte, Tracy and Sam, you can clearly see that these are massive challenges and could serve a massive gain to the NHS at large. And from a commercialisation perspective, just to get you a bit more excited really, I think they do have a massive potential for quite a wide market. So that's really exciting. And the key thing from my point of view, from my work in SBRI, the brilliant thing with working through SBRI is that collaboration and team support that you get. So you'll have access to amazing amount of networking within the NHS in Wales to work through the solution with the key players who obviously brought that challenge to you today. So massive opportunity. Just wanted to add that in.
Brilliant, thank you. And just to double check, Faye, there's no more questions that have come in. I'll just wait for Faye to respond.
No, nothing else.
Okay, I just thought I saw someone's hand up. Okay, brilliant. Again, there's the web email address there if you do think of anything else you want to say. But again, thanks everybody. Best of luck with your applications, and we very much look forward to seeing your ideas. Okay, thank you. Bye.
Thank you.